will they be speaking to you in Thai or will they be speaking to you in English?
No, English.
English. I was hoping that they'll speak in Thai so that we'll get to understand some Thai language. Huh?
Yeah. You need to learn more.
Okay.
Thailand more often.
True. Let the virus go, then we'll come for the other virus. Correct.
So
Okay.
Asavri, are we all set on the OrthoGuru platform? I assume we're starting at 3 o'clock sharp, right?
No, she's not there. I can't see her anywhere. Saurabh.
Oh, okay. So OrthoGuru host, she was managing that.
Acha, she's that. Okay. She's muted there. Dr. Reddy's also joined. I can see him joining now.
They should show their face.
They should show, right?
You tell everyone to show their face.
I think they should. So when I think you're presenting, let your face view be on. When say Bancha, you're presenting, all of us will be on mute, of course, and we'll get rid of our face as well, so that we don't distract people.
Okay.
Dr. Hi, Manish. Hi, everybody.
Hi.
There you go. How are you, Chief?
Greetings from Hyderabad.
Yes, sir. How are you doing? All well?
I'm very well, Sachin.
So, Saurabh, you are going to introduce the program first, the initiative, the faculty, and then will you be inviting Dr. Shekhar to make his presentation?
No. So I'll just start off with a brief introduction, and you being the moderator, I'll hand it over to you for a quick start, and then kick starting while introducing Dr. Shekhar to start off with his presentation.
Oh, okay, fine, perfect, not a problem.
Dr. Sachin?
Yes, sir.
Sir, how many hours webinar nowadays for you?
Now I'm becoming selective now. One day was crazy. I did 8 hours of webinar.
Oh God.
that was worse. Now not more than 1, max 2 a day. That's it. So today I've got 2. So that's enough now. I mean, the ones that I've already committed to, I'll honor them, but the others, I think. Okay. OrthoGuru has started screen sharing.
Last time, Babu. So everybody should be muted.
Yeah, so we are already live now. I'll just ask Dr. Saurabh to start now. Just give me a minute.
Okay.
Dr. Saurabh, please
Yes.
do start. Over to you, sir.
Good afternoon, everyone. Thank you for joining us today online. I am Dr. Saurabh Sharma, Director, Medical Education, South Asia, Smith & Nephew. And I welcome you all to this All Around the Knee web series. This web series is an extension of our flagship education event, All Around the Knee, to ensure that we continue our commitments towards medical education. This concept of a web series has been designed as an exchange platform wherein knee experts from across South Asia gather for peer-to-peer learning through presentations, case discussions on unique and challenging topics in knee repair. This version of series is focused on PCLs, and as we go by with the series, we would cover interesting topics like pediatric ACLs, complex meniscal repairs, extra-articular ligaments, and much more. Today, as we are beginning the series 1 of All Around the Knee, we are honored to have amongst us the best in the game from India and Thailand, touching upon every important aspect of PCL injury, repair, and subsequent patient outcomes. Leading the web series all the way is none other than Dr. Sachin Tapasvi. His name needs no introduction for the work he has done in knee arthroscopy globally. His commitment, passion, and enthusiasm in medical education is remarkable. He has been extremely forthcoming and helpful in putting through this scientific, technology-driven medical education initiative. Thank you, Dr. Tapasvi. We are delighted to have Dr. Bancha from Thailand. His global experience in knees is extremely invaluable, and we are honored to have him today presenting his case, thoughts, experience, and wisdom with you all on PCLs straight from Thailand. We also have distinguished knee experts from India, Dr. Shekhar Srivastav, Dr. KJ Reddy, and Dr. Mukesh Ladda, presenting interesting and challenging cases in PCL category that would incite us all to ideate, debate, understand, and further bring their learnings, experience into our practice and improve patient outcomes. Thank you everyone for being a part of this meeting. As the faculty presents, all the viewers can submit their questions on the tab that you see on your screens. The faculty will address them after all the presentations are over. Without taking more time, I would like Dr. Tapasvi to give his opening remarks and kickstart the meeting. Dr. Tapasvi will be the moderator for the session. Over to you, Dr. Tapasvi.
Yeah, thank you, Saurabh, and it's a great pleasure to be here on this afternoon, on a Friday afternoon, to try and look and engage with all of you, especially looking at problems with the PCL injured knee, which is not a very common scenario in our clinical practice. So we're going to try and get together a couple of representative cases on this subject. The first presenter is going to be none other than Dr. Shekhar Srivastav. So Shekhar, can I ask you to please share your screen and your presentation now? Dr. Shekhar Srivastav is a consultant knee surgeon at the Sant Permanent Hospital, which is in New Delhi, and he carries a rich experience of a lot of knee as well as shoulder arthroscopy and arthroplasty procedures. Today, he's going to be engaging with us on a specific diagnostic or therapeutic dilemma as to how do you treat a sportsman who's got an isolated grade 3 PCL tear. Over to you, Shekhar. Shekhar, you can start please now. Thank you.
I think he has got disconnected. His screen is freezed.
Looks like his internet is unstable probably.
Yes.
That's why. So I think what we'll do is it possible for you to get him out of his screen share?
Yeah, I'll do that.
Can you do that, please? If you're able to do that, then what we'll do is that by the time he gets called and gets logged in, I would then request Dr. KJ Reddy then to come in with his case so that in the interest of time, we can carry on. So Shekhar, are you with us?
No.
Shekhar, are you with us or we'd lost you actually?
Sachin?
Yeah, okay, lovely. We'd lost you actually.
Okay, yeah. So can you see the screen now?
Yeah, now we can see you. You can please start presenting, please.
You can hear me also?
Absolutely perfect, yes.
Okay, thank you. Thank you. So thank you for the introduction, and I thank Smith & Nephew for inviting me for this webinar on case-based discussion on PCL management. Okay, so here's a case of 17-year-old gentleman, and he's a wrestler in one of the akhadas in Delhi. feeling to a local there, but he was and sometimes he would feel some
I think it looks like probably Dr. Shekhar Srivastava is having some problems with his internet connection, if I'm not wrong. I think I'm going to just take this initiative and I'm going to please invite Dr. KJ Reddy to present his case. So Dr. Reddy, if you could please share your screen and your case with us. So Dr. KJ Reddy is a very senior consultant in sports, arthroplasty, as well as trauma surgery. He's based out of Hyderabad and he heads the prestigious Apollo group of hospitals from Hyderabad. Today he's going to be presenting to us his case scenario where he talks about very not an uncommonly seen situation. Basically, he's going to talk about how does he manage a PCL avulsion fracture. Dr. Reddy, please.
Yeah, can you see my presentation?
You need to share your screen, please. There's a small green button at the bottom of your screen which says
I've done that.
Share. If you could please hit that and then
Can you see me now?
Presentation. Yeah, we can see you now. I think you'll have to just go to PowerPoint, open that and go to show. Wonderful. Thank you so much.
Good afternoon, everybody. Thank you for the opportunity. Smith and Nephew, a good, excellent initiative. As someone was commenting, Sachin is very busy, becoming an epidemic webinars now. Anyway, it's a great opportunity. So as Sachin said, I'm going to share straightforward, but I think the management, how we're going to manage, because sometimes common problems can be treated inadequately. So this is a 23-year-old male, had injury, hyperextension injury, and came to my clinic with the pain, swelling of the knee, difficulty in moving the knee, and also difficulty in weight bearing. It's about 2 days old injury. That's an X-ray.
Okay. So
we can see the X-ray.
Yes, we can see the X-ray, and we can very nicely sort of see here as well that your patient shows the presence of injury in this area here. Correct?
Yeah.
Perfect. So, what is going to be your further management, or what is going to be your plan? How you're going to approach this case now? We're probably looking at a PCL avulsion fracture.
Yes. So I think probably I would do an MRI scan and find out the status of the PCL as well as what's happening with the rest of the knee joint, because as we know, PCL may not be isolated injury. It might have associated injuries, maybe ACL or menisci. So we have to rule those one out and plan our treatment. Can you see the, that's a magnified view, I think probably.
Yeah.
That's a MRI scan, as you can see the MRI scan. An MRI scan, there's a clear evidence, there's the avulsion of the PCL. And you can see the ACL. ACL looks normal. Can you see, Sachin?
Yes, absolutely. We can see that the ACL is looking normal, its integrity there.
Yeah.
And the PCL on this section is appearing displaced from its normal insertion point. We can see it in this image here as well. Yeah. So,
and I can say the rest of the menisci are normal.
Yeah.
There was no any damage to the menisci.
Yes.
So, shall we discuss what would be the next plan of action?
Absolutely. So, what would be your line of treatment now based on these MRI images?
Yeah.
So, I'll get your
It is isolated. It is isolated PCL avulsion with the displacement.
Okay.
So, I would like to, I think, fix the PCL, and I would prefer doing open surgery.
Okay. So what in your case will constitute the correct or the adequate amount of displacement for you to decide that this probably will be the appropriate amount of displacement? So after what limit of displacement will you say that, okay, I am going to offer surgery to this patient?
Yeah. If it is about 10 millimeter displacement.
About 10 millimeters. I'll ask the panel to give their opinions as well. We'll start with you, Billy, then we'll move to Bancha, Shekhar, and then Mukesh. In your practice, what degree of displacement is sort of for you a significant amount of displacement? Billy. You'll have to unmute yourself, Billy, and please talk.
More than the displacement per se, it's also the translation that I take into account.
Yes.
So if I got, my threshold is more than 5 millimeters of displacement, and translation more than 10 millimeters.
Bancha?
So,
Bancha, unmute, please. Bancha, you're muted.
Okay.
Yeah,
So
yeah.
5 millimeters accept. So and
Okay.
also examination. If there associated injury, I will go in, right?
Okay.
5 millimeters and associated in injury. And if you found the examination, they have the laxities. Yeah. Acute situation is difficult to test, right? So we look at things and associated,
okay.
right?
Yeah. Shekhar, what's your cutoff point displacement wise?
So if the posterior drawer is 2 or more,
Yeah.
and if it's even if it's 5 millimeter, I would go ahead and fix it, because that will give me an opportunity to fix the PCL anatomically.
What about you, Mukesh?
Maximum up to 5 millimeter.
5 millimeter. There's a question from Dr. Prashant here, Dr. KJ Reddy, as to when was the MRI done? Was it immediate or did you do it after, say, a couple of days?
No, 2 days.
After 2
2
days.
days old injury. This is, yes, 2 days.
So a question to the entire panel: when you get a patient who's got an isolated PCL avulsion, when will you do an MRI scan? When will you do, or what would be the ideal time for all of you to do an MRI scan? Any quick answers from the panel?
I would look at the extraarticular soft tissue that I can see clinically. If there's a lot of extraarticular soft tissue, I would wait a week or 2 before I take an MRI scan, unless there is an indication to go in early to address the PCL.
No, we're talking about an isolated PCL injury.
I would wait a week or 2 because I'm not going to rush in to fix that.
Okay. Any different thoughts on when to do investigations?
I don't have to wait. Why you wait? Because if you do it acute, you can see the hematosis. So it's like you do MR with arthrogram. You can see the pathology better. So I never wait. I do it right away.
Okay.
Yeah.
Any
can
changes?
I, Sachin, can I? There was no significant effusion. As you can see the MRI scan, not much of effusion.
Yes.
If too much of effusion is going to interfere with MRI, probably I would have waited. But I fully agree with Dr. Bancha. There was no need to wait, because if you keep waiting, I don't think we are going to achieve anything and put the patient very anxious. So there wasn't any significant effusion.
Okay.
That's the reason we went in, because there's no associated injuries. That was the reason did an MRI scan. But I don't have any hesitation to do MRI scan immediately.
Okay, fine, perfect. So we've looked at your MR scan. Can you take us further through your case, please, now?
Yes.
May I add something to it?
Sure.
Yes, Mukesh. Quick comments.
And on X-ray, as we can see, there is a displacement of PCL avulsion fracture. I won't wait for MRI. If it would have been an undisplaced PCL avulsion, then would have waited for it.
Okay, fine. Okay, point taken. Yes. Yeah, you could go through your case, please.
Sachin, another point. For the accurate PCL avulsion, most of the time you have no effusion in the joint because it is extra-articular, right?
Correct.
But if you have effusion in the joint, you should thinking about the associated pathology in the joint.
Yeah.
So in that situation, I think we will do MRI right away.
So that's a great point, Bancha, that you've rightly got out this aspect that when you have a PCL avulsion, because it's extra-articular, usually the joint will not be swollen like what you see with an ACL avulsion. And if you definitely see an avulsed, if you see an effusion, then I think you should be more suspicious as to there is something that you should be looking out for. Okay, so the next question which Dr. KJ Reddy has for the entire panel is, what procedure would you choose? Open, arthroscopy, and timing of the same. Quick answers from the panel. We'll start with you, Billy, then Bancha, then Shekhar, and then Mukesh.
I would go arthroscopically.
And timing when?
Since there is no capsular tears in the MR scan, I would go straight away.
Bancha?
Arthroscopic surgery.
When?
Right away.
Okay, Shekhar?
Same, arthroscopic surgery.
Okay. And when?
Within a week's time.
Within a week. Mukesh?
I'll do open surgery very soon. And if it's only communicated PCL avulsion, I'll go arthroscopically.
Okay, so Dr. Reddy, you want to tell us what is your preference and why, please?
Yeah, if it is not comminuted with a lot of good fragment, I would do open, because it would give me easy access, simple operation, and I would be quite comfortable bone-to-bone attachment. If it is a comminuted, yes, I would go for arthroscopy, but otherwise I would go open. And I don't see any point in waiting, because is an extraarticular, as Bancha said. I think I can do within few days time.
Okay, perfect. So your choice is to do an open surgery. Yeah. Okay. Can you talk us through your steps of doing open surgery, please?
Yeah. This is, I think, probably will come later, probably. So my planning will be, I would like to discuss a little about position, incision, approach, fixation, and of course, especially the screw length. Position is a prone position with a radiolucent table, so that I can get my C-arm in and see the intraop picture, and put the patient toward the end of the table. I use the tourniquet. Incision would be a hockey stick incision with the transverse crease, transverse part, either transverse crease of the knee, and the vertical part on the lateral aspect extending, on the medial side of the calf, about maybe up to 7 centimeters. And I would expose the interval between the tendon of the semitendinosus and the medial head of the gastrocnemius. Semitendinosus will be retracted medially, and medial head of the gastrocnemius laterally. Popliteus and the flexor digitorum longus will be in the floor, in the interval. I do subperiosteal dissection of the popliteus muscle to identify the fracture line. Of course, this Buck-Shaffer, the approach uses the interval between the medial gastrocnemius muscle and semimembranosus tendon. This approach avoids dissecting neurovascular structures in the popliteal fossa as well, but does not provide adequate exposure to the lateral base of the PCL and the capsule. That's, I think, shall I continue with the video?
Yes, you can, please.
Can you see the video?
Yes, please go ahead.
Yeah. Can you hear the voice rather?
No, there's no voice in your presentation, but you'll have to talk us through it.
You can see the exposure. The important part is identify the bony fragment, and take the bony fragment, freshen the ends, and try to reduce it. Hold with a temporary K-wire, guide wire, and put the second guide wire through which you're going to put your drill bit as well as screw, and use the partially threaded canceller screw with a washer, and it should reach the anterior cortex, so that we get a reasonable hold. And most of the time, single screw would be good enough. And make sure you check under the C-arm your screw position, and if required, further tightening.
Fixation of our single, partially threaded 4mm cancels release screw.
Yeah.
All retractors within the
You can see that is the semi-tendinosis and medial head of the gum.
Yes, we can see that very well.
And as you can see the guide wire, that's the same pictures. So it's important that the screw length, it reaches the anterior cortex, and it's most of the time it's a 4mm cancelless partially threaded screw with a washer.
Yes.
And most of the time it's a single screw.
Okay.
That's, I think, again, just a picture showing it is important to freshen the ends of the fragment as well as on the posterior aspect of the tibia, so that you can get a anatomical, a good reduction and doesn't slip. When you put in guide wire into screw, if reduction is not good, it tends to slip away from the position. So it's very, very important. Put the fragment back. I will put a small K-wire or a guide wire away from the center where you're going to put a definite screw, so that it prevents the rotation when you're putting the screw in.
Okay.
And that's the post-op picture. Before I start that one, any questions, any discussion, Sachin, you want to?
Yeah, so I think there are a couple of questions that we have here, and I'll request all the panelists also to join in for the discussion.
Yeah.
The first is that how do you evaluate after you've put in your screw that your reduction is adequate? Do you do a posterior draw with the knee, with the patient in the prone position, or how do you know that you've taken away the laxity?
Yeah, that's, I think, a very good question. Sometimes could be difficult, but once you get your good reduction, it should come back, but you can do posterior draw, which would be difficult in the prone position.
Okay. Any other specific tips from the faculty who have experience in fixing these fractures open? So I think, Mukesh, you made a point that you'd like to do this open. So can you tell us how you assess the stability?
So when we see the lateral view on the C-arm, I just give a posterior translation through the anterior tibia and see how much it is translating on the X.
Correct. Yeah. Shekhar, you want to make a point?
No. I wanted to ask Dr. Reddy that sometimes I find it difficult to retract the medial head of gastrocnemius, especially in muscular persons.
Yeah.
Okay.
So do you have any tip for that?
So what Dr. Reddy advocates is not a Berkshire posterior medial approach. He advocates a posterior lateral approach. And that is the next question that we're going to come to. Having done both types of approaches, posterior medial and posterior lateral, which do you feel is an easier approach to do in terms of safety, in terms of exposure, and why?
You're asking me, Sachin?
Yes, absolutely.
Yeah. I think, as I said, posterior lateral, to be honest with you, I think you keep practicing, I think most of the approaches would be easy. But I do more often posterior lateral. The only reason, it's easy to reach the lateral side and do the capsule as well on the lateral aspect. So I prefer most of the time it's a posterior lateral rather than posterior medial. And Dr. Shekhar, I think my answer would be, if you flex the knee little bit, it will relax the gastrocnemius. And you get, but it's bulky people, it would be difficult, but I think that's what I do. Little flexion of the knee might help to expose more of the posterior part of the tibia.
Mukesh, do you do a posterior medial or a posterior lateral approach?
Posterior medial approach.
So what is your trick to tackle, bulky muscles?
As mentioned by Dr. Reddy, flex the knee, and if still it's very difficult, I'll just partially exercise the medial head of gastrocnemius.
So you release it of its insertion on the femoral condyle, correct?
Yes, sir.
Okay, perfect. Right. Another question coming from the participants today, Dr. Reddy. Would it be better to use a suture anchor rather than a metallic screw in terms of fixation?
Probably you can, I would be more comfortable because if it is a reasonable fragment where you can take the head without breaking the fragment, I would prefer a screw because better fixation cortex to cortex, you will have a superior than suture anchor. That's what.
So,
but it's a small one where
Yeah.
you are likely to break. Probably you can use a suture anchor.
So I think I would probably agree with you. I think the amount of compression that you get with a partially threaded cancellous screw, which is engaging both cortices, is definitely far more better and more secure than a suture anchor, because the pull-out strength will not be that great in that metaphyseal area. There's another question, which is a very practical question, which I think I have also faced in my clinical practice, is that when we're passing a screw in an open fixation, the fracture fragment breaks. So if you're overzealous, then it can break. So how do we avoid this? So does anyone of the faculty have any tips? We can start with you, Dr. Reddy, first. And if any of the other faculty have faced this situation and have any specific ideas, please feel free to share them.
Yeah, I think that's the most common complication and you should avoid as much as possible. As I said, if you fix it not in the center, away where you're going to position screw with one more small K-wire or guide wire, so that most of the time it breaks if it is not reduced properly and it's not held properly. Keep moving, wobbling around, then it tend to break. So temporarily fix with one more guide wire before you put the proper guide wire in the middle of the middle of the fragment, and always check the thickness of the fragment. You should go in the thickest part towards the center. If it is in the thinnest part, what happens tend to break.
Okay, perfect. I think that's a good point. Bancha, you want to make a point? Yes.
Sachin, I have some point. You can use the spike washer, okay, to put this in. Even it's break, no problem, because this spike washer can press it down. And also you can back up with suture. So not just the screw, you suture on the bone tendon junction, bone ligament junction, and drill to anterior cortex. Okay, so then you back up, you pull and tie over the post anteriorly, and also you fix the screw. So even the screw break, you have no problem because you back up by tying to the post to the anterior cortex.
Yeah. So I think that's a great bailout option, and I think that's something that one should always sort of keep at the back of the mind. I think that's a very good point. Even if when you're dealing with comminuted fractures, if you've got a lot of comminution, it will make a lot of sense to put a couple of whip stitches through the ligament till the junction of ligament and bone, and then take them out as a pull-out suture, bring them out from the front and fix this. Bancha, I'd like you to make one last comment before we move further ahead as to what in your hands, because you've been fixing these PCL fractures for a long time, you've done open, you've done arthroscopic. So now, what in your mind is a definite indication for open and what is a definite indication for arthroscopic?
So nowadays I do purely arthroscopic. In the past I do open, but there's some problem when you need to come back for knee surgery, like joint replacement, or you have fracture, you need to put the nail in something. So you need to go to the back first. And the arthroplasty guy, Bremy, you come here, you remove the screw first. So that's why I stopped. And I think that nowadays the suture material is quite strong. You can do minimally invasive surgery using arthroscopic approach. Okay, it's not a big deal. And even comminuted fragment, you can do arthroscopic surgery because you're not dealing with the bone. You're working on the ligament. Okay, and just pull it through. No problem. Even the bone is comminuted. So I myself nowadays I stopped doing open. I do arthroscopic 100%.
100%. Since how long now?
Since 7 years now.
Okay, perfect. So Dr. Reddy, can you take us through your rehab protocol for this particular patient as to what would be your guidelines for rehab, please?
So I think the most important part, I keep telling everyone, immediately post-op in the recovery, you must check for the neurovascular status.
Yeah.
Because, and you document it, especially for the younger surgeons. That's my tip. You must check for the neurovascular status and document it. And I put them in a brace in extension for 6 weeks. And passive knee bending will be started about 4 weeks. And the brace will continue up to 6 weeks with the partial weight bearing. And depending upon the X-ray, probably at the end of 12 weeks, full weight bearing, and going back to sports maybe after 6 to 9 months.
So how do you evaluate your patients post-op?
Yeah.
Do you do routine
Post-op.
X-rays or CT scans? What's your way to evaluate?
Yeah, most of the time it's an X-ray. If reduction is good and it's healing up, sometimes what happens is there will be fracture line visible and you may have a fibrous union. In that case, I would do a CT scan to see what kind of union, completely non-union or a fibrous strong union, and also assess clinically by clinical examination. Clinical evaluation is very, very important. Even there is a fibrous union, if clinically it's a stable knee, I wouldn't worry too much about worrying about that fibrous union.
Okay, fine. So I think some great points there from Dr. Reddy. Thank you so much for presenting your case. We'll stay on the same topic. I'm going to ask Dr. Billy Paul Wilson from Chennai to come in next. Dr. Billy, can you start sharing your screen, please?
I will.
And Dr. Billy is the Chief of Arthroscopy and Knee Surgery at the Miyot Hospital in Chennai. And he's absolutely a great person when it comes to looking at, all these ligament reconstructions. He has a wealth of experience with him. So over to you, Dr. Billy, and he's going to shed light on a different view of the same topic. He's also going to be presenting on PCL avulsions, but he's going to be talking as to how he uses arthroscopy to do the same. Billy, over to you, please.
Yeah. Can you see my screen there?
Yes, absolutely. Please go ahead.
Okay, so having heard from Dr. Reddy about open fixation, and probably I'll now talk about an arthroscopic fixation. And like Dr. Bancha said, for the past 5 years, I've been doing PCL avulsion fracture fixation arthroscopically, because I find that the chance of finding a concomitant intra-articular pathology is much higher arthroscopically. And I've had patients who have had open fixations in the past come back with problems for which I had to scope later on. So in my hands, I go with arthroscopy fixation. Now, my first patient that I'm presenting is a 25-year-old male, an MBA student. He had a road traffic accident, two-wheeler versus two-wheeler, and his anterior aspect of his shin hit the bar against the bike. He was able to weight bear with pain. He had a very deep abrasion in the anterior aspect, anteromedial aspect of the proximal shin. When he presented, he had a mild effusion. He was able to bend his knee to about 0 to 90 degrees with comfort. And I was able to assess his laxity. He had a sag of grade 1 and a posterior drawer of grade 2. So this is the X-ray that he presented with. And you can see on the X-ray, there's hardly any effusion that you can see. And you can see a fragment there. Of course, he had an MRI scan that was done, as well as a CT scan. For this presentation, I'm just showing the CT scan, and that's what the CT scan looked like. There was a bit of a comminution at the base, but the vast majority of the chunk that was attached to the PCL was intact, albeit it was a smaller chunk. And so that's the situation I was. And so I've decided to operate on him arthroscopically. Have you got any questions at this point?
No, I think you're pretty good. We'll take all your questions once you finish your case.
Right.
Yeah.
So that was the examination under anesthesia. And you can see I operated on him about 10 days later. I waited for the abrasion to heal a bit because of the technique that I used to fix the fragment anteriorly. And so this is my operating setup. I have a C-arm on the side and a standard supine position, a knee standard arthroscopic fixation. And also, if there is a slight laxity, it does not actually translate to poor outcomes. And the only thing that you need to be aware of is there is a slightly higher risk of arthropfibrosis. And so if you're aggressive in your post-ab rehab, I think they do really well.
Thank you. Thank you so much, Billy, for your lovely presentation. And we have a couple of questions for the panelists now.
Yeah.
The first question which I have is that, why is it so that we, in an open approach, fix the fragment at near full extension, whereas when we're doing an arthroscopic approach, we fix it at about 90 degrees of flexion? Does that have any implications on the stability of the knee post repair?
For me here, it is a fracture that we're dealing with. So as long as your fracture is down into the crater, it doesn't matter what your tension is. So for me, the position of the knee doesn't matter in a fracture scenario.
So when you're tying sutures anteriorly through your transtibial drill holes, will you give an anterior draw like what you do in PCL reconstruction, or will you just leave it as it is?
No, I do give an anterior draw. I do give.
Okay. So another question is that what are the chances of fluid extravasation and how do you avoid this particular problem?
Okay. So the important aspect of it is it tends to start extravasating once you violate into the popliteus muscle. So as long as you are staying very close to that, your dissection is mostly on the medial aspect. And when you're just about ready to define the crater posterolaterally, that is when I open the posterolateral capsule and into the popliteus. But once you have reached that, you're running against time. I've had instances where the calf does swell up, but the fluid gets absorbed very quickly. I squeeze the calf out. So far, touch wood, I have not had any issues with neurovascular compromise postoperatively.
So, I mean, on the same note again, is that how many portals do you make? Do you always make 2 portals? Can you do it with 1 portal? Do you require a transeptal approach? Can you do it with 2 posteromedial portals? What's your take on this?
So if I'm using a suture bridge technique, I use 2 portals on the posteromedial aspect to clear the tissues, define the crater. But if I'm doing kind of in an acute scenario, an in situ fixation with a suspensory fixation, I can get away with just 1 posteromedial just for my sutures to be retrieved through for tightening.
Okay, Shekhar, what's your take on this? How many portals do you make? 1 or 2 posteriorly? You need to unmute yourself.
So I usually make 1 posteromedial portal, and I clear that septal tissue, and I make 2 windows, one between the PCL and the medial condyle, and another one between the ACL and the PCL. And I try to do my suture management and visualization through these 2 portals. So sometimes I take my scope through the window between the ACL and PCL and try to look medially and then try to manage the suture.
So you'll make 1 posterior portal.
1 posterior portal,
Okay, Mukesh, how many portals do you make posteriorly?
1 posteromedial and 1 posterolateral. Clear the septum.
Okay. Bancha, how many portals do you make posteriorly for your PCL arthroscopy?
1 posteromedial, 1 posterolateral. And in the front, we have 3 portals. We have anteromedial, anterolateral, and mid patellar tendon because I need to retrieve the sutures. And I think the key point is you need to make a tibial tunnel lower than the fracture site. Because if you make it lower than fracture site, when you pull, it's like you do rotator cuff. This is the suture bridge. You know, the fragment will sitting above, just above like you do rotator cuff, the lateral low should be lower. So this fragment will perfectly attach at the anatomic position. That's
And what's your trick, Pancha, to prevent compartment syndrome and extravasation of fluid? Do you have any specific tips?
No, you make it fast.
You just make it fast.
Yeah.
Okay.
Don't make too much pump. Just gravity enough. Okay.
Perfect. Okay. So I think thanks, Billy, and thank you so much, Dr. Reddy, for highlighting the PCL avulsion. I think, Shekhar, if your internet speed is up to the mark now, then maybe we'll have you come in with your presentation, please, which is essentially looking at grade 3 PCL, isolated PCL tear.
So is it clear now?
Yeah, perfect. Lovely.
Okay. So I think
yeah.
Okay. So should I start from the beginning?
No,
So
you
this
can,
is
this is
just
fine.
a
I think
recap of this
yeah.
thing.
Yes, yes.
A 17-year-old gentleman, a wrestler, aspiring wrestler, and while sparring with his partner, he had this injury in his knee joint, and he got treated with his local doctor. At that time, there was some swelling and pain, and that slowly subsided. Now the problem is that he has come back. He has come to us 8 months after the injury. He's not able to give his peak performance, and that was the so there was no effusion at that time, and no specific tender point, and the posterior drawer was grade 3. Can you see the pictures?
Yes, we
Sachin?
can see. Yes, we can see the pictures. Please go ahead. Yes.
Okay. So when the posterior drawer was grade 3, so we decided to do the stress X-ray, and that was the picture. On further examination, his collaterals were okay. The dial test was negative, both at 90° and 30°. So that was the dial test at 90° and 30°. And that was, if you can see at 90°, the left knee, there was a sag sign. So that's the right knee, and that was the left knee. Now, when we did the latchman, it was falsely positive because the set point was posterior. So it was basically coming from the posterior sag position to the normal position. And when we traced along the medial femoral condyle, so that should be the normal position when we were giving the anterior drawer. And when it was left and we gave the posterior drawer, then the tibia was behind the medial condyle of the femur. So that's the situation now. A young guy of 17 years, he wants to become a wrestler. He sustained injury to his knee joint 8 months back. He is unable to give his peak performance. The posterior drawer is grade 3. All of the ligaments are okay. Neurovascular status is okay. So how do we take it forward? What to do?
Yeah, so I think Shekhar, you've brought about a great point here. So here we have a high demand person because he's a wrestler, and definitely at the end of 8 months he's not getting any better. And as what we see on your clinical profile, he's got gross laxity. So I'm quickly going to go through the panel. I want short and crisp answers from everyone as to what would they do surgery, yes or no, and what would be their graft choice and what would be their surgical choice. So Billy, surgery, yes, no?
So definitely I'll operate on him.
Yes. Graft choice?
Graft choice will be hamstrings.
Okay.
My technique will be a transtibial, possibly a double bundle, depending on the graft.
So hamstrings, harvest graft from both knees.
Both sides, both knees.
Do both sides and do a hamstrings single or a double bundle. Correct. Dr.
Yes.
Reddy? Unmute please yourself. Can you kindly unmute yourself, please?
Yeah, I would go. I think I would agree with Billy. Nothing. I would go for surgery, double bundle, hamstring.
Hamstring. Bancha? Unmute, Bancha. Bancha, you need to unmute yourself, please. Bancha, can you unmute yourself?
Yeah. Okay. You hear me?
Yeah.
We use the hamstring both sides.
Both sides. Mukesh?
I'll go with the peroneus longus for PCL, but considering the amount of posterior sag on stress X-ray, I doubt whether he really has only PCL. There has to be associated posterolateral corner also. So if I'm doing that, I'll go with the SEMI-T for posterolateral corner reconstruction.
But you'll do single bundle peroneus longus.
Yeah, remnant preserving single bundle peroneus longus.
Shekhar, you will tell us what you've done, but you can also participate in the discussion and tell us as to what would be your graft choice in this particular situation.
Okay. So, again, reconstruction. Cases I have used hamstring graft.
Yeah, unfortunately, I think we've lost Shekhar again. Shekhar, I think we've lost you again. We've lost your presentation. We've lost your presentation one more time. Shekhar, can you hear us? Hello? No, I think we've lost Shekhar completely this time. We're very sorry about that. Because we really can't, I think his internet is completely unstable. So sorry about this. So I'm going to, unfortunately, I'm going to ask the next presenter, that is Mukesh Ladda, to please come on. We'll try and reach out to Dr. Shekhar Srivastava and see what is happening with this net there. So Mukesh, can you please come on and can you please discuss your case and what your case scenario is? Thank you so much.
Is my screen visible?
Yes, absolutely. Please go ahead.
Am I audible?
Yes, you are.
Okay. So some different scenario here. In case if you see a chronic PCL deficiency with a varus malalignment. So this is a 50-year-old female patient, sedentary lifestyle, housewife by occupation and obese. She had history of injury to a left knee, dashboard kind of injury 20 months back. And she was diagnosed to have PCL avulsion fracture at that time, and it was managed conservatively by the orthopedic surgeon. Now she complains of pain in both knees, left more symptomatic than the right, pain more while climbing up the stairs and also while walking. She had to take support of something while coming down from the stairs, limp while walking, pain worsening now slowly and affecting the activities of daily living. There are no sudden onset of any symptoms, no mechanical or catch pain, anything like that. Clinically, she had full range of motion. Varus thrust grade, Clancy sign was positive. Posterior sac, posterior drawer grade 3. Dial test positive. Varus stress test positive. MCL, ACL was intact. There was a mild retropatellar tenderness over the medial aspect. These were her x-rays, long-standing, as well as weight-bearing AP and the lateral x-rays. That's
right.
a schemogram. Yes.
Right, Mukesh. So it's a left knee, correct?
Yes.
Yeah, then you can please continue to share your screen. Please don't stop sharing your screen.
Okay.
Yeah. Please stay in the presentation. Can you open the slide and go to full screen mode, please?
Full screen mode only.
Yeah, go.
Yes.
Yeah, and now bring on your last slide. Okay.
Yeah.
So fine. You want us to discuss the left knee now, and what
Yes,
we
sir.
see from your case profile is that we're looking at a lady who is in her fifth decade, sorry, and she's got a chronic PCL unstable knee, and she's developed osteoarthritis, correct?
Agreed.
Okay, fine. Right. So can you please share with us her additional imaging, because definitely you'd want to get an MR scan done. Are you happy to share that with us? And can you discuss the findings with us, please?
That's the intact ACL.
Yes.
That's the PCL avulsion, almost 20 months old. You can see some small cartilage lesion on the patella. Intact meniscus, anterior horn and posterior horn of medial meniscus with some signal changes, but they are grade 1 to grade 2. You can see subchondral marrow edema in the medial joint space and the reduction in the medial joint space. So she had medial joint OA with intact meniscus, intact ACL and collaterals. So it's an isolated PCL avulsion with posterolateral corner with varus alignment.
Why do you say posterolateral corner?
Clinically, it was lax posterolateral, dial test was positive also.
So how often will you see someone who gets a PCL avulsion along with a posterolateral corner disruption?
In acute, I may not see, but this is a chronic 20 months old. So this might have led to a varus thrust gait as well as the varus deformity. There might have stretching of the posterolateral corner and capsule.
So you would want to sort of drive home the point that there are 3 types of varus knees. You
Yes,
have the single varus, double varus, and the triple varus knee, correct? So can you
Yes.
please tell us what is single varus, double varus, and triple varus?
Single varus knee, when there is only a varus of 5 to 10 degrees, there is no associated varus thrust gate and no posterior laxity. Double varus is varus with a thrust, and then the triple varus is along with FFD.
Along with the FFD. Okay, fine. Right. Okay, fine. So can you now tell us what you've done and what were your different thought processes?
So the options we have: fixation, either open or arthroscopic.
Okay.
So I
Fixation
think,
of the PCL fragment.
yeah, for
Okay.
me, strictly no, because it's a 20 months old.
Yes.
Another option, will someone go and try for isolated PCL, PLC reconstruction, single or double bundle, the choice? I still think isolated reconstruction is strictly no because of associated varus malalignment.
Okay.
Someone may offer HTO with PCL reconstruction, single stage. I have no experience with this, so I'll not go with that option. My option here is a high tibial osteotomy with sagittal plane correction, increase in the posterior slope. And later, after say 1 month to 18 months, if she is comfortable doing nothing, and if required, may go for PCL later.
Okay. So opinions across the panel. What would all of you do? What would be your choice? Let's start with Billy first, and then we'll move on further and we'll ask the other panelists then.
Now, I just want to put this span in the works. When I looked at an MRI scan, it's full thickness chondral loss that I can see.
Yeah.
And to me, it's an arthritic knee. She's in her 50s. I would probably offer her a posterior stabilized totally replacement.
And get done with it once and for all.
Absolutely.
Okay. That's one good option that you can definitely consider. Dr. Reddy, what would be your take on this?
Yeah, I think probably I wouldn't venture into doing a H2O because of full thickness. Probably I would do a unicondylar replacement because the ACL is intact, collateral is intact. Probably she got a good range of movements, no fixed deformity. I think she would do well with the uni.
But you're not worried about her PCL being lax there?
I think it's a contraindication.
And also her postlateral corner being lax, as what Mukesh is saying.
Yeah, I think I didn't take that one. Yes, I'll go for a total knee replacement. Yes,
Shekhar,
right.
are you with us? Can you tell us what would be your?
But I couldn't see his cases, so.
Oh, okay.
Pictures, so.
Okay, Bancha, you want to make any comments? What would be your take on this? Bancha,
This patient have chronic PCL avulsion, also the PL, right? Also they have medial compartment osteoarthritis.
Yes.
So I do STO.
Okay.
STO, because STO you can solve the medial joint line pain, right? And also the lateral side will be better. The PL also when you do STO open wedge, the PCL posterior drawer will also be better. So after that, we evaluate the patient again. If they're happy, that's fine. But if not, we can come back again to augment the PCL or PL. But I first attach with ISTO open wedge.
So as we can clearly see here, there are two schools of thought. I mean, the panel is divided between two options. We have the joint preservation surgeons on one side who would want to preserve the joint, and because she's in her early 50s, maybe try and give her another 10-15 years before she goes metal. And we, on the other hand, we have again the joint replacement sort of focused panel, which wants to go ahead and replace her joint. So I think this is definitely a dilemma, and probably both are correct, both are not correct at the same time. If you ask me, what would I do? I would err towards joint preservation because she's essentially did not have too many symptoms. So Mukesh, you have to fill us in on this one. So before she had this injury, what sort of discomfort levels did she have in her knee? That's the first question.
As per her history, she was quite comfortable. She didn't have any issues.
So if she was one of those who had a lot of knee pain and had discomfort, had difficulty in activities of daily living, before the injury, then probably even I would have erred on arthroplasty side, but probably here I would like to give her the benefit of doubt. So now once you are probably sort of engaging us to do a high tibial osteotomy and a sagittal plane correction, can you take us through the steps and can you tell
May
us
I
the
add
rationale
something
behind
to
this?
it for the joint replacement, guys? If you
Yes,
closely
please go.
see the X-rays, they are not great for osteoarthritis, and MRI always overrides whatever we do. So I was reluctant to offer her knee replacement surgery because they were all weight-bearing X-rays, and the virus was not that too much. So I didn't offer her replacement. I offered her HTO.
Okay, that's a good point. Yes, Billy, you want to make a counterpoint? Yeah. Okay. Right. You wanted to tell us?
So the steps, so some articles which says that if there is a PCL insufficiency for about say 1 year, the medial femoral cartilage loss increases by 3-fold. And if it's combined with PLC, then it significantly increases the cartilage degeneration. The article is by Dr. Strobel. Another article also mentions the same, that the increased in medial compartment osteoarthritis if it's a chronic PCL deficient knee. So the role of osteotomy, the medial open wedge osteotomy along with the sagittal plane increase reduces the forces on the posterolateral structures and the posterior articular cartilage. So the slope correction has to be taken care when you are doing an HTO along with a PCL deficient knees. This was another nice article which have a 5 to 15 years follow-up and published in 2016. The tibial slope strongly influences knee stability in posterior ligament reconstruction. So isolated PCL deficiency in a patient with a flattening of the posterior tibial slope, chances of PCL failures are much high. So much stress has been given about the posterior tibial slope in managing the PCL deficiencies. So what exactly it does, it anteriorly translates the tibia if you increase, thereby reducing the axial forces on the joint. So this is how I do. I take a midline incision just medial to the tibial tubercle. Identify your MCL in the upper border of your pes hamstrings. And here I take my first beath pin under the CCTV coverage and point it towards the head of the fibula. See that you don't violate and stops about 1.5 centimeter distal to the lateral tibial plateau and just at the head. Then pass your osteotome after taking a cut with the saw just on the lateral, on the medial tibia, and pass your osteotome under CCTV coverage. Stack your osteotome so that you have a controlled opening of the osteotomy, thereby avoiding the fracture of the lateral cortex. And as per your pre-operative planning, you decide how much you want to open. As I wanted to open here somewhere around 8.5 to 10 millimeters. So that's how you do. And one more important point when you do osteotomy, see that you completely break the posterior cortex before you try to open the osteotomy. Otherwise, it will propagate the crack intra-articularly, or you will have an inadvertent opening of your osteotomy. Then, if you are doing osteotomy only for varus knee and not manage much about slope, then the posterior part of the osteotomy should be double the anterior opening, as you see here, with the help of your lamina spreader, so that you retain the original slope of the patient. But in this case, I had reversed it by putting graft anteriorly and opened much on the anterior aspect. And I did increase in the slope, and this is what I did, and that's the post-op X-ray with increase in the slope and medial open wedge. That's the calculations. Open for discussion.
Okay, do you have a post-op scanogram for us to have a look?
This is only 2 months old right now.
Okay.
So, and due to this corona, I'm unable to see the patient, but this is what X-ray she had done and sent me 6 weeks back.
Okay. So now
so I don't have a post-op scanogram right now.
Okay. So now can you go to the last X-ray one more time, please? The AP view. Right. So the question that we want to ask you here is that this, your standard Mikulicz, where do you want your new axis to pass? Medial tibial spine, lateral tibial spine, or Fujisawa point?
I won't prefer to go to the Fujisawa point because it's too much of overcorrection. I'll go to the neutral axis.
So, but when there is, what was the arthroscopic view? Did you do an arthroscopy at the same time, or you did not do an?
No, ideally, you may say you have to do arthroscopy with the clinical findings of chronic symptoms, no mechanical catch, and MRI showing no meniscal injuries or anything. I didn't do arthroscopy.
You did not do an arthroscopy.
No, I didn't.
I think I would have done an arthroscopy. I mean, that is my view completely, because depending upon what was the quality of cartilage, I would have then dialed in the amount of correction. What was your new tibial slope now? What was the new tibial slope?
These are the calculations.
So can you tell us how do you calculate tibial slope?
Exactly, take the center of the tibia in the dead lateral view.
Yes.
Take two, and I have taken two lines on the anterior and posterior aspect and perpendicular to that. And then you have to take the posterior cartilage where the exact turn is there, posterior cartilage anterior tip. And then you calculate that as pre-op you see that's a 7-degree posterior tibial slope, and post-op it's almost 14-degree now.
Okay, fine. Any comments from the faculty? Any questions, any queries, any points for discussion in this particular instance?
Yeah, I would agree with Dr. Sachin. I always scope my patient, a quick scope before I do my osteotomy. And again, depending on if it's a full thickness chondral loss, I would err on moving your mechanical axis as further as possible, but not into the Fujisawas.
I also completely agree, but there are two schools of thought for the guys who are doing all the deformity corrections. They say clinical lateral joint line tenderness is a more important clinical parameter to suggest whether there is any lateral compartment problem, as well as your MRIs. Because most of the deformity correction guys, they not do scope. I do scope, and I agree with you that ideally you should scope also. What's the thought of other panelists?
No, I was thinking more in terms of not scoping the lateral compartment, but to know the exact status of the medial compartment per se to see how much I'm going to shift.
Okay.
So, because you said it was not a grade 4 on weight bearing.
Yeah.
Okay, Bancha, I have a question for you. Now, let us say that we have someone who is 35 years old and has a non-union PCL avulsion, which is 4 months old. Okay, 4-month-old PCL avulsion, 35-year-old person. The alignment is neutral. What will you do?
So I try to get in first. I go to the back of the joint, transeptal approach.
Okay.
So I try to manipulate that fragment and put the suture in and try to pull it down. But once it's not easy. Most of the time, I suture that fragment down into the tibia and then augmentation with another graft. So I do like PCL remnant augmentation and also pull that fragment into the socket as much as I can, right? So that's my approach.
So you will try and sort of preserve all that remnant and do a PCL reconstruction at the same time.
Right.
So you will leave the bony fragment behind, or you will take it off?
So if I cannot reduce it back, I try to make it smaller. I shed, and then augment this graft, this remnant to the new PCL.
Okay.
If I cannot put it back to the anatomic position, otherwise the film X-ray post-op look ugly. I don't like that. Okay. So in case you cannot reduce that, please shave it to make it small. Okay.
Yes, I would agree with you.
Yeah.
Perfect. Okay. Any other
Sachin,
comments?
Sachin.
Yes, Dr. Reddy. Yes.
Can I ask you, of course, just putting in a different way, can I ask you, Dr. Mukesh, if there is no PCL deficiency, how would you manage this patient with similar symptoms, similar findings, with intact PCL?
With a simple HTO, maintaining and trying to retain a posterior slope, as I already mentioned there.
Okay, you won't consider uni.
So for uni, there are specific criteria: bone-on-bone disease, correctable varus, intact ACL.
Yeah.
So here it's not on bone-on-bone. This is not grade 4 bone-on-bone. This is grade 3 to me.
Okay.
Fine.
Agree.
Okay. Shekhar, are you okay with your internet speed actually?
Dr. Bancha wanted to comment something, sir.
Yes, Bancha, sorry. I stopped you. Yeah. Bancha?
Muted.
Yeah,
Yeah.
muted. Yes.
Yeah, I have short comment about STO. If we are a keyhole doctor, whenever we do STO, please put the small keyhole and put the scope in.
Okay.
Advance the intraarticular pathology, because we are not the arthroplasty guy. Okay.
Point well taken.
Yeah, we are keyhole doctor. Keep in
Yeah.
mind.
Yeah.
We miss the intraarticular pathology because STO, you treat the axis, you treat the physics, right? But you didn't treat the intraarticular pathology. Sometimes we miss that.
Okay. So Mukesh, there's a question from Dr. Thongchai. When you change the tibial slope, does it change the biomechanics of the knee, and how?
Definitely, it will going to change a biomechanics of knee because the tibia is more anteriorly translated here. So,
how does it change the biomechanics?
As it causes more anterior translation of tibia and axial loading.
So please explain how change of slope, either increase in slope or decrease in slope, will change the biomechanics of the knee joint.
Sorry, sir, I may not be able to answer that. Please, can you take it on?
Okay, so essentially what is happening here is that when you have a high slope, with a high slope, you try to increase the slope to counteract a PCL deficient knee. So when you have a PCL deficient knee, the tibia is translated posteriorly. So when you increase the slope, it gives a better chance for the femur to get reduced onto the tibia. On the contrary, when you have a ACL deficient knee and the tibia is translated anteriorly, when you decrease the slope, the femur removes underneath the tibia. So essentially, the most important thing is that you may definitely want to get the femur reduced underneath the tibia, and the contact pressures actually improve when you have this reduction of translation done, because when you have a subluxed posterior or anterior tibia on the femur, the contact pressures are quite high. Once the tibia and the femur are reduced underneath each other, the contact pressures are reduced. And when Bancha does present his talk on the neglected PCL injured knee, he will highlight that point as to why is it necessary to reduce the tibia underneath the femur adequately. Okay, so there's another question that's coming up. Mukesh, you can take that since your case was the osteotomy. Are there any absolute indications to do an osteotomy when you have chronic PCL insufficiency versus doing a PCL reconstruction? So to rephrase the question, when you have chronic PCL insufficiency and you do a coronal plane scanogram X-ray, at what angle on the X-ray or what complaints of the patient will you decide that I am going to shift over and do an osteotomy as well?
So if it's a chronic PCL insufficiency, I'll look into the age of the patient, the activity level of the patient, the alignment of the knee.
Okay.
And if the knee alignment is normal and the sagittal plane also, the posterior slope is within the normal limits, I will not do anything HTO. I'll do either single bundle PCL remnant preserving PCL reconstruction along with plus minus PLC injuries associated.
Okay. Fine. I think that's a fair answer. We'll now ask Shekhar Srivastava to come in, please, and finish off his case. Shekhar, we have our fingers crossed that it runs through this time. So Mukesh, can you please stop your screen share? Yeah, thank you.
Okay.
Good.
Sachin?
Yes.
Okay. So I do apologize for this technical problem, and I hope this works this time. Yeah.
So this time we won't stop you. This time we don't stop you. Just go through the presentation and we'll ask you questions afterwards.
If it doesn't work, you can play it from your end. It doesn't have the video, but at least you can show the post-op pictures.
Okay, we'll do that. Yeah.
And then I won't try from my end. Then
yeah.
So I decided to take the quadriceps graft, and I decided to do the arthroscopic double bundle technique.
Yes.
Am I audible? And you can see the
Yes,
pictures?
yes, absolutely
Okay,
fine.
okay,
Please go ahead. Yeah.
Okay. So my thoughts for taking the quadriceps graft was that initially I used to do hamstring graft, but at the end of 5 to 6 months, I used to see this posterior sag. So I felt that it used to stretch out a bit. I was taking both symmetry as well as gracilis. Yes, I haven't tried taking hamstrings from both the sides. But quadriceps, I found it to be a very stiff graft. And second thing is that it has got a natural cleavage, which can be used for double bundles. So you can use a 3-tunnel technique where you can put 1 tunnel in the tibia and 2 tunnel in the femur to reconstruct both the bundles of the PCL, that is the anterolateral bundle and the posteromedial bundle. So that was my thought for taking quadriceps in this patient. I use the full open technique to take the quadriceps tendon graft, though now the instruments are available to do it in a mini open technique. And we take the central part of the quadriceps tendon around 1 centimeter in thickness. And that gives a very good cross-sectional area of the tendon along with a piece of bone to gain the length. So we got a graft of around 12 centimeter with a width of around 1 centimeter. And that's the natural cleavage plane. This is the part of vastus intermedius, and that is the superior part, which is made up by rectus femoris and vastus medialis and lateralis, and you prepare the graft like that. Then that's the intra-articular part. Can you see the video?
Yes, yes, we can see the video.
Okay, so that shows the lax ACL, and because the tibia is sagged posteriorly, then through the posteromedial portal, we are bringing the shaver and we are clearing the tissues behind the tibia. Now, as we discussed before, we have to go around 1.5 to 2 centimeter below the articular surface of the tibia so as to avoid the killer turn. Now, one point I would like to mention here is that you should always face your shaver towards the tibia, and you should be very careful with your suction. As far as this extravasation is concerned, I never use a pump. I always do it on gravity-assisted fluid management. And then we bring the guide to for the tibial tunnel, and it is approximately 1 point. You see, that's the 2 centimeter, 20 millimeter mark. So our exit point will be around 15 millimeter beneath the articular surface. And here comes the femoral part. Now, PCL, the femoral attachment of PCL is quite big. It's a fan-shaped structure, which extends quite from here, 11:30, coming right up to 8 o'clock. So if you want to cover the footprint, then you need a big, big tunnel, or with a single bundle, sometimes it's very difficult to reconstruct that. That's why I think double bundle works in a better way. So that's the point for the anterolateral bundle, and somewhere here will be the posteromedial bundle. Now I'm not running the video because it might again stop. So that's why I'm just rushing through these videos. And that's the graft going into both the tunnels. So that's for the anterolateral bundle, that's for the posteromedial bundle. Now at this point, you have to be careful with the suture management. Now the tunnels are drilled from outside in, and these grafts will also be fixed from outside in with the screws. But first, we do it in a sequential manner. We first fix it in the tibia so that we can tension both the bundles separately and fix them. So here you can see the tibial tunnel, which is coming right like this. So it's approximately 1.5 centimeter beneath the articular surface so as to avoid your killer turn. Normally, whenever we do PCL with this graft, the graft ends somewhere here inside the tunnel. So I put a scope inside the tunnel, put my guide wire under guidance, and then put the screw. So here is the bony plug, and that's fixed with the screws here. That's the immediate post-op X-ray. And that's the X-ray after 6 months. And here you can see that the graft has incorporated with the bone, and there are no lyses around the screw sites. So that's the clinical picture of the patient. I haven't put the video of posterior drawer. It did go down a bit, which was immediate post-op, but it's still much stiffer than what I used to get with hamstring graft. Sachin?
Thank you so much. So
Yeah,
I think
so-
this is a really nice way of bringing about, and there are a couple of pros and cons with the different graft choices for PCL reconstruction. Well, you can argue both ways. The way that you've shown is that since it is an isolated grade 3 PCL, you require a more robust graft. You need to recreate all that collagen footprint since it's an isolated injury. And that's why I think it is completely justifiable in using a quad tendon graft with a bone plug. And you can differentially tension the two bundles on the femoral side, which helps you achieve the same stability. All the same, also your plus point could be that you are not harvesting from the contralateral limb, so that in a person who's a wrestler, probably that is also a point that one should consider. So I mean, to sort of give a take-home message, I think it's really important to really understand what we should be doing. Single bundle versus double bundle has always been a debate. The biomechanical studies in the lab have shown that double bundles are far more better than single bundles as regards to stability and rotation. But in the clinical scenario, both of them are absolutely the equivalent. One technique has not shown superiority over the other, especially as far as clinical outcomes are concerned. With respect to graft choice, when you have so many different graft choices, that really means that no single answer is correct. Each one will have better results in their own hands. And definitely one important aspect to consider is that though you may choose either a hamstrings or an allograft or a BTB or a CQT, one thing which is very important is that you should never have a thin graft. You need to have a graft which is going to sort of try and cover as much collagen as possible, and your tunnel should be not less than 9 millimeters, even if you're doing a single bundle PCL. I actually would try and get at least a 10 millimeter tendon bundle in. So thank you, Shekhar, for your case. We'll move on to the last case for today. We're going to invite our guest, Dr. Bancha, who needs no introduction. Dr. Bancha is from Thailand, and he has a vast experience of treating knee dislocations. And he's going to discuss and describe to us how do we tackle this particular issue where we are faced with someone who has a neglected knee dislocation with a predominant PCL component. Bancha, over to you, please. Thank you so much for joining us. You'll need to unmute yourself, Bancha, please. Bancha, please unmute yourself. Yeah.
Can you hear me now?
Yes, Bancha, I can hear you very well. Please.
Okay, good. So thank you for invitation. So I'm talking about the neglected knee dislocations. Okay, this is not, I think, not so rare. I see it about 3-4 cases a year. Okay, most of them refer to me. So let's go to the first patient. This is 68 years old male. He has motorcycle accident. So most of the knee dislocation in Thailand is motorcycle accident. So he had the knee dislocation and he was immobilized in the cast. Okay, and after that, refer to us. So this is the examination. You can see that there is the dimple on the medial side. Okay, so this one was immobilized in external fixator, not cast. Okay, you can see that this is a pinhole external fixation. So the Walker stress test is 3+. Okay, and also the patient have anterior posterior drawer test positive. Okay, so that is the examination. It's 3+. So from the X-ray, you can see that you can see this invaginate into the joint, right? You can see the soft tissue, and laterally will look not too bad. So that's why the first patient, the first doctor, they just immobilize. So you can see that this is the buttonhole, right? This is very common, the rotational instability, and the medial condyle is getting out and protrude getting out of the capsule. So this is the MRI. You can see that all the MCL is torn and invaginate into the joint. This is the MCL. You cannot see any MCL on the femoral side. It's getting into the joint and entrapped. So the PCL and the ACL also torn. So this is the very common irreducible dislocation. Okay, it's always torn the medial side, and it is like this classic manifestation. Okay, from examination you can see the dimple. So what we have to do is to open, right? When you open, you see the condyle underneath the skin. Okay, and then you use your finger, okay, to pull the MCL getting out of the joint, and then I repair the MCL back into the femoral condyle. Okay, and then I put the exofixator, because, and very important, when you put exofixator, you need to make sure that the medial and lateral joint space is equal, because in the KD3, KD4, sometimes you over tension and the opposite side is open. So I also prefer to put the exofixator in the center, because it can control the medial lateral better, right? So that's my way to do the, first we need to open reduction and reduce. Okay, after that, this is about 6 weeks. After that, we remove the exofixator and encourage the patient to move. Okay, so after that, this is 3 months after the initial. So the patient have better motion, he can go 120. So at this time, I'm coming back for the ACL and PCL reconstruction. Okay, so we can see some remnant of the PCL. Okay, that's the ACL. I do ACL and PCL both at the same time. Okay, so PCL I use peroneus longus. The ACL I use a hamstring from the opposite side. Okay, that's his ACL and that's PCL. And I immobilize put the screw in nearly full extension, 0 degree. Okay, and I put my PCL screw close to the joint. And ACL screw, I use button for PCL and ACL, and also I put the screw at the tibial side. So after that, okay, this is the 6 weeks after the second operation. Okay, the patient getting better, and also his motion getting much better. Okay, valgus and valgus is not too bad now. Okay, it's much better than previously. Okay, so this is the first patient. We have 3 patients. Okay, the second one, this is a 41 years old motorcycle accident about 5 months. So the patient came to us with the right knee pain, and he cannot extend the knee fully. There's some subluxation of the tibia. You see that? He cannot extend the knee. There's some flexion contracture, and also the tibia is persistent sagging, persistent subluxation. Okay, that's his problem. So this is an intraoperative examination. We can see that posterior drawer positive, also valgus stress test positive, 3+. So this patient, I get into the joint, then I release everything because his knee is subluxed posteriorly. Okay, so I release the scar tissues and go into the back by the transeptal technique. So this step very important. You can see from here that the tibia is sagging. See that tibia is sagging to the back. Okay, this is tibia, this is femur. So this is tibia, this is femur. It's persist a subluxation to the back. So I release everything in the back, transeptal, and also I release the capsule from the femoral side, tibial side. Okay, that way. Okay, everything in the back. And after that, we do the manipulations to make sure that the patient can get. And we need, you see how many fellow we have. You can count the hand, 1, 2, 3, 4, 5, 6, 7, so many. So make sure that the joint space is equal. I check the x-ray that the knee is in full extension, and also the medial and lateral joint line is equal. So that's important, that you need to reduce and put the in external fixator. So that is the alignment of the knee. And after that, after surgery, the patient can keep full extension. So I wait for 6 weeks, okay? And after that, this is after remove the external fixator, 6 weeks, the posterior sacking is getting better. So we're coming back for the PCL and ACL and PLC reconstruction, okay? So PLC, I did this patient have intact popliteus. So I just do the percutaneous LCL reconstruction. We make 2 small holes, 1, 2, and make the tunnel like that, and pass a graft to the femur. And at the tibia, at the fibula side, I drill from fibula to tibia, okay, and fix that with screw or button, okay. Fix it 3 cortex that way. So that's a minimally invasive PLC reconstruction and PCL reconstruction. So this is 3 months after the surgery, okay. The posterior sacking is good, while stress is also much better, okay. So patient happy. So we have the small scar tissues. So the third patient, so this is 29 years old. He had neglected knee dislocation for 1 year because this patient had head injury also. So at the beginning, the neurosurgeon said he is hopeless. So he was in ICU for like two months. So they neglect the knee joint. So this is quite common in our situation. Many times the patient that have head injury, the extremities, sometimes they neglected because sometimes they thought that this is hopeless. So this patient come back with this dislocation. Also, there's some heterotopic ossification. This is a CT angiogram. The vascular is good, and also the peroneal nerve is intact. So this is his examination. You see that the knee joint is underneath the skin, like that. Okay, and also extensor mechanism is all gone. So we're starting with the talar fascial frame to distract the soft tissues. But I asked my colleague, the pediatric surgeons, because I'm not good in this talar fascial frame. So the pediatric surgeon, they said, oh, he cannot do any longer because it's very tight. So he asked me to get in arthroscopic release first. So I use the arthroscopic release, getting in. It's quite scary because the knee is still subluxed and anatomy is all distort. So I keep close to the bone, right? This is we going to the notch first. Remove everything, ACL, PCL, and this is the arthroscopic ossification in the back. We remove everything. Okay, release the scar tissues, release the posterior capsule. Okay, and after that, we can distract. This is the after we release and remove the arthroscopic ossification. You see that here is gone, the arthroscopic ossifications, and we can distract that much. Okay, but anyway, the knee is still cannot reduce because this is stuck in the soft tissue on the skin. The bone is underneath the skin, and patella is all gone, patella tendon, and also the cartilage in the jaw is all gone. So I discussed with the patient that there's the only way because you lost your extensor mechanism, you lost your cartilage, you lost all your ligament. So the only way for you is to do this knee fusion. Okay. So we did the knee fusions. Okay. And this is about 6 weeks after the knee fusions. The patient is really happy. She can come back to walk again. He's quite happy because he's in this position in wheelchair for 1 year. Okay. So another thing that I need to warn you is that if the patient have neglected dislocation, when you go to the back of the joint, like these patients, I get in slowly. Okay. Especially the patient have done the open knee surgery before. Okay. So these patients, I get in slowly, but yeah, especially at the tibial side, you see the vessels, I cut the popliteal artery. Yeah. So I feel so sorry about that. You see that? So I need to ask the vascular surgeons to come and then help me. But anyway, I need to finish my job because the vascular surgeon, when you consult, they will come about 1 hour later. So during this period, I finish my job. I do PCL, I do posterolateral reconstruction, everything. Okay, but I'm not so happy because I know that this needs no vessels. And after that, we do the reconstruction, PCL, PLC. And after I finish my reconstruction, medial lateral side, so the vascular surgeon come and fix the vessels. Okay. So here is the vessel, it's gone. You see that? There's no vessels. So that is all my conclusion. Take home message for this is that the knee immobilization, we saw a lot of neglected patients because we taught by the senior doctor that we should immobilize the knee in 30 degrees. This is wrong. The patient have knee dislocation. If you put in this position, the knee will subluxed when the cast is loose. So stop doing this. You should put it in full extension, okay? And check the x-ray again after you put the cast on. Okay, check medial lateral joint space should be equal and no subluxation, no recurvatum. Okay, very important. Check the x-ray again. And don't miss the diagnosis because sometimes when the patient has multiple injury, especially head injury, fracture femur, fracture tibia, hip dislocation, or fracture, we are focusing on the fracture. We forgot the ligament. Okay, and when your patient come back again, this is neglected and knee is already subluxed. Okay, so number 2, don't miss it. So this my step of the neglected dislocation. First, you can do arthroscopic assisted or you can do open, but key point is you need to reduce the knee first and immobilize. Most of the time you need external fixator because cast is not enough. It will sublux in the cast. So external fixator is very strong. And you can do the medial side, lateral side at the same time. If the patient have neglected and they have torn medial lateral, I do that at the same time. Okay, but I leave my PCL and ACL later. After you remove external fixator, wait for the patient to have the better range of motion and we come back for ACL and PCL reconstruction later. Okay, that's my algorithm. So the last message I will give you is neglected dislocation is challenging. Prevention is the key. So don't miss the diagnosis. Don't miss that. Okay. So the hint is when the patient come to an emergency room, if you see hyperextension of the knee or severe valgus, valgus deformity in 0 degree, you have dimple side. Okay. Thinking about the multiple dislocation because many times more than 50% this dislocation is reduced spontaneously. Perfect reduction. Check the x-ray every time. Make sure that the medial lateral joint space is equal. And in lateral view, it should not have no subluxation, even in cast or in external fixator. Or the last message is correct immobilization. Put the knee in 0 degree, not 30 degree. Okay, thank you. Sachin.
Yeah, thank you, Bancha. That was indeed a very elaborate overview of this very difficult problem. I mean, essentially, that's a huge volume of work that we see here of this very difficult topic. Anyone has any questions for Dr. Bancha on this very sort of very difficult topic? Yes, Dr. Reddy.
Yeah, I think that was excellent presentation and demonstration of cases. I'm just wondering, what would be your incidence of neurovascular injury for a knee dislocation? Because we find it very high. Majority of the cases will have neurovascular injury. What is your experience?
Yeah, in our practice, it's depending on the type of dislocation. So if you have the posterolateral injury, there's almost have the peroneal nerve palsy, okay? Or the patient that have the posterior dislocation, they may have the higher chance of the vascular injury, okay? So in my practice, overall is about 5 to 10%. Okay, it depends on the severity.
Yeah.
May I ask?
Yes,
yes please.
Dr.
Mukesh,
Bancha?
yes.
you state that you will reconstruct PCL and ACL in the later stage and collaterals in the first stage,
Yeah,
and
right.
mobilize the patient for 3 months.
Yeah,
So
right.
then how you take care of that posterior sag? Won't that posterior sag will have more detrimental effects on your collaterals because of that persistent sag?
That's right. That's right. Because actually you can do PCL but no ACL. You can do
Agreed.
PCL because if you do PCL together with the collateral with exon fixator, that will help exon fixator. And during the rehabilitation, the sagging will be prevented by the PCL, right?
Yeah,
So
yeah.
I agree with you, but it's a lot of job at that time. So
Okay.
you understand that that's
I
not,
got it.
yeah. You can do that. You can do PCL, collateral, and then put in exon fixator. Okay.
Yeah.
Dr. Bancha, a
Yes.
question for you.
Yes, Billy. Yes.
A couple of questions. The first one is, I know mechanically a central midline external fixator is much stable, but do you have instances where your quads get stuck down and you have to release that at any point? That's my first question.
Yeah, I know that this way, exon fixator in the center, no one do that because in the textbook, they recommend you to do lateral for the femur and medial for the tibia, but that's not good. I prefer to put in the center because you can control medial lateral better and also easier for me. Okay. I have some problem about the pin at the femur. Okay. But you need to make very good care of the pin. Okay. I always use the antibiotic ointment put around the pin. Pin care is a key point. And also when you drill on the femur, you just drill only one cortex, not do two cortex, because two cortex will lose very fast. You drill on only one cortex and then you turn the chance pin in. It will be very stable. Okay, just one cortex. That's another trick. It will not lose. Okay.
The second question was related to the young guy who ended up doing an arthro disease. We know that if your joint is not congruent and it's been staying out for a long time subcutaneously, your articular cartilage is going to go away. So why did you attempt distraction and reduction? Why didn't you go for an arthro disease straight away?
You cannot because it's very tense. Because the soft tissue contracture is too much. You see the initial x-ray is subluxation, that's too much. If you try to do one stage, it's too scary. You know, you can turn the vessels. So I recommend you to distract first. So the vessel will slowly allow you to, so that it will be safer if you do two stage.
Okay.
Thank you.
Thank you. Any more questions? So I think it would be safe to conclude by saying that when you have neglected injuries, you have to respect the principles which Dr. Bancha has outlined. I think he's outlined them really clearly in a very crisp manner. And I thoroughly enjoyed this, the last maybe not 90, almost 105 minutes with the webinar, where we had a lot of interesting points brought out by all our eminent faculty. And I would again thank Smith Nephew to give us this opportunity for updating and updating ourselves during these very challenging times. And I'll hand it over to Dr. Saurabh Sharma to try and give the concluding remarks. Saurabh, over to you.
Yeah, thank you so much, Dr. Tapasvi. So we are much over time. For the viewers, if you still have any questions unanswered, please send them through Smith & Nephew representative or email to Smith & Nephew Medical Education team, and the faculty would be glad to answer them back for you. I would like to thank all the faculties for taking out time and sharing their knowledge with us on the various aspects of PCL and staying committed towards medical education. I'm sure there will be a lot of learning and takeaways for all of us today, and that will help definitely improve patient outcomes. Thank you so much and have a nice day ahead. Thank you so much for participation.
Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Bye, everyone.
Bye.
Bye.
Thank you. Thank you.
Bye.
Thank you.
Thank you.